Well, golly, let me go ahead and Brett, I can share my screen, right?
Yeah. It's available. You've got it.
Alrighty, let's see how funny it goes here. Okay, there we go. Well, let's go to let's go to slideshow here. There we go. Okay. Hey everybody, great to be back again this year. I know last year I talked some about, well, a fair amount actually, about exercise oncology and clinical breast cancer. Joining us right now, I think she's still there, is my wonderful boss at Maple Tree Cancer Alliance, Dr. Karen Wonders. And the talk that this is a new talk, at least this year, not only put on by myself, but the majority of the slides came from Katie Schmitz, who just recently left Penn State and has moved to the University of Pittsburgh School of Medicine, and also Dr. Karen Wonders, who is the founder and CEO at Maple Tree Cancer Alliance. For all talks that are CME, I always have to do disclosures. For Medtronic Technologies, I'm a speaker. I actually teach nipple-sparing mastectomies. I actually have a textbook out a few years ago on the subject of nipple sparing. At Lumicell, which is looking at margin assessment, I actually chair their data safety monitoring board. And then at Maple Tree, I'm the chief medical officer. I do it out here in California. Maple Tree is located in Dayton, Ohio. I'm a newbie. I'm an absolute newbie to this area. But I'm excited about it because of all the data that's there. If we look at the setting of cancer worldwide, it is estimated that in 2020 that 18.1 million individuals were diagnosed with breast cancer and 9.6 million died from it. The World Health Organization states that cancer is the leading cause of death worldwide, accounting for nearly 10 million deaths in 2020, roughly one in every six. Most common, just like it is in the States, worldwide is breast, lung, colon, and rectum and prostate. In the United States alone, the lifetime risk of developing cancer in men is around 40%, nearly the same number in women. And in 2018, 1.7 million individuals were diagnosed with cancer in the US at a cost of, Casey Brown was talking about 140 billion. I've got a number of about 158 billion. What's not counted are the billions of dollars of additional loss to disability, lost work, lost household productivity. So the burden of cancer remains a significant public health issue worldwide. Now, I was just at the College of Surgeons meeting down in San Diego, and I was teaching at a course there, and I said, all right, how many of you, put up your hand, how many of you have ever heard the term exercise oncology? In the room of 50 people that I was talking to about nipple-sparing mastectomy, not a single hand went up. And so what is exercise oncology? And we've got Karen Anderson back on with us. And as I said earlier, the Aussies have been real leaders in this. But I'd like to define it as the adjunctive therapeutic approach to cancer patients emerging from several thousand. And I really want to emphasize this. This is not woo-woo, folks. This is several thousand prospective, often randomized clinical trials conducted over the last 20 years, many of which, as I said to Karen Anderson, are from Australia. What these clinical trials have resulted in is really strong evidence, and I mean really strong evidence, of the positive impact of exercise on patients' fatigue, their anxiety, their depression, particularly quality of life, their physical functioning, sleep, bone health, breast cancer, and particularly breast cancer-related lymphedema. Exercise oncology programs are evidence-based programs of supervised, individualized exercise training done on site, or as we had to experience during the pandemic, virtually. The goal, and my goal at least, and I think Dr. Karen Wonders' goal, is to make exercise oncology programs an international standard of adjunctive care, as it already is in Australia. I think many of you are aware of the American College of Sports Medicine, Exercise is Medicine. This is simply more of this. Without going into the details, if you look at randomized clinical trials and all clinical trials of exercise plus cancer or physical activity plus cancer that are either randomized or not, and by physical activity here, I'm talking about jogging regularly as an example, or playing tennis regularly, or even golf or other regular crewing or whatever they can be. Look at the number of these trials that have gone on over the last 20 years. And the number of actual randomized clinical trials has gone up nearly 300%. As I said earlier, the American College of Sports Medicine has been a big leader in this world. In the Journal of ACSM in 2019 was their roundtable report on physical activity, sedentary behavior, and cancer prevention and control. There were a huge group, including folks from Australia, Canada, and the United States that participated in this. So one of the things that came out of this is, what about exercise for cancer prevention, let alone being involved in treatment? So for all adults, exercise is important for cancer prevention and specifically lowers the risk of 7 common types of cancer: colon cancer, stomach cancer, esophageal, bladder, kidney cancer, endometrial, and of course in breast cancer. And as you know, Exercise is Medicine has been copyrighted by the American College of Sports Medicine. So we start looking at the aggregated data. This is a slide, again, that I got from Katie Schmitz, summarizing these 12 studies starting back in 2004 through to 2017. And if you look at the polled estimate, in other words, post-diagnosis physical activity, what's the impact of post-diagnosis physical activity on cancer survival? And the number is 0.69, which translates there's a 31% reduction in cancer mortality if we can get people exercising. And I'll show the standard for that in a minute, after they've been diagnosed. What about physical activity on breast cancer recurrence rates? Now, this is much smaller, from a group of 5 studies that were coalesced. And the number here is 0.78, which translates into a 22% reduction in recurrence risk. And then more importantly, or as importantly, what about looking at all-cause mortality? In other words, not from breast cancer, but all the other causes. This is, again, a study, a coalescence of 13 studies from 2005, again, up through 2017. Here's even a bigger number, 0.59, now translates into a 41% overall reduction in mortality. And this slide simply summarizes that. Physical activity, coalesced studies put together, big numbers here. These are real numbers. Here's a couple of studies that are really interesting about keeping people in chemotherapy regimens. We've got 2 studies from 2007 and 2015. And as many of you know, there's often a requirement to adjust dosage in chemotherapy, especially when I get down here. Well, in a prospective study involving an exercise group and usual care, there was a 3-fold decrease in the likelihood of the exercise group that you'd have to adjust the dose of needed chemotherapy. Same thing down in dose-dense therapy and other dose densities. Again, in the usual group, around 84% were compliant versus almost 90%. So again, the impact is quite real. So exercise, what are the exercise guidelines during breast cancer treatment? Well, they're to improve symptoms and side effects, as we talked about, and I gave you the list of those. What's recommended is 3 times weekly aerobic exercise, moderate exercise, for 30 minutes per session. vigorous walking. One of the things when I bring up exercise to cancer patients, they somehow suddenly think that I'm talking that they're getting ready for a 10K race or they're getting ready for a half marathon or whatever. That's not what we're talking about. We just got to get people out and moderate exercise 3 times a week and twice weekly doing some strength exercise. Maple Tree is a not-for-profit, started over 11 years ago in Dayton, Ohio. When we look at the components, what goes into an exercise oncology program, if any of you know much about cardiac rehab, you're going to see some real similarities here. We want to do pre-screening, or it's called prehab, if we can, once the diagnosis is made. We want to then do a fitness assessment, and out of that baseline fitness assessment, create an individualized exercise prescription. And when I get done with this talk, Karen can come on and elaborate some more on these, then put the programming together and then do reevaluations. So these are the 4 phases that we've got at Maple Tree. Again, very similar to cardiac rehab, which is really the founder of so much of this. We're doing more and more neoadjuvant chemo, particularly in triple negative and HER2 new positive breast cancers, as well as for rectal cancers now, prostate cancers, and others. So we can get people going before they even start. That would be great. Phase 1, which lasts 12 weeks, is during chemotherapy, or if we get them during radiation therapy. Phase 2 generally follows phase 1 after the completion of chemotherapy, can then involve also radiation therapy, or if patients who are strongly estrogen receptor positive and didn't need chemo therapy, or for that matter, may not even need radiation therapy, but are going on anti-hormonal therapy, that would be phase 2. Phase 3 then is out in long-term survivorship. And one of the things I talked about last year that I want to emphasize again, we look at exercise oncology as a continuum of the hospital sort of based acute treatment. And then long-term, we feel more and more this can occur in the fitness industry and are starting to coordinate more and more with the fitness industry. Many people have said to us, well, gee, why aren't the physical therapists doing this? Well, a lot of the physical therapists are involved with orthopedic issues or lymphedema. Very few licensed physical therapists are actually focused on cancer rehab. And so we see this as a continuum between the clinical, the rehabilitation side, and the wellness side. In many instances, we know exactly who to refer initially to a physical therapist, who will then say, hey, continue working with the certified oncology exercise specialist, or to get together with them initially. Now, here's some real data from Maple Tree, summarizing the experience with 11,248 patients. I presented some of this last year, but these are big numbers. When we look at the physical and psychological impact of physical therapy on quality of life, it's nearly 60% improved. Cardiovascular endurance, about 15%. Muscular endurance. Think now for a minute, if the typical cancer patient is just going home and sitting on the sofa, they're going to lose cardiovascular muscle endurance, let alone flexibility. And so the impacts here are real. But here's something that's really important, making the patients feel more positive, nearly 76%, particularly pre-pandemic when they were involved with their on-site exercise oncology certified specialists. They bonded with those specialists, or if they were in small groups, they did as well. And increased feelings of support, nearly 60%, real numbers. Now, Casey Brown was talking about hospital stays and increased ER visits during his talk a while ago. We just recently submitted an abstract to the American Society of Breast Surgeons off this pool of a prospective study that I'm going to show you in a minute. But just off of this pool, a decrease in inpatient hospital stays of about 6%. The length of the stay is nearly 20%. Here was, and this number is very, very similar on the prospective clinical trial, and I'm going to show you in a minute, around almost a third decrease in ER visits, total patient encounters, again, about a third, 33%, and readmission rates. So not only are we having an impact on how folks feel, but there's a very real fiscal impact here. Getting back to the roundtable, the second paper they put out is the exercise guidelines for all cancer survivors. Again, several folks from Australia, Canada, and others, big international group, put out in 2019. And this is what came out of that group, a little bigger number of 150 to 300 minutes per week of moderate intensity activity. When you think about it, that's 5 days a week for 30 minutes. And again, twice weekly resistance training. In the world of breast cancer, we have the National Accreditation Program for breast centers that certify multidisciplinary breast centers across the country. They're revising their standards, and some new standards are coming out that will include exercise. But this is the big breaking news this calendar year. And I brought this up earlier when I commented with our medical oncologist talking about anti-hormonal therapy in men. This is the ASCO guideline that came out in March, April of this year. Remember, that's the American Society of Clinical Oncology. Let me read this verbatim for you. Oncology providers, whether it's surgeons, medical oncologists, rad oncs, whoever, should recommend regular aerobic and resistance exercise during active treatments with curative intent to mitigate side effects for cancer treatment. That's a really big deal. It's not quite as strong as the COSTA statement down here from Australia, but getting close. The NCCN guidelines, I'll talk about them in a minute, do have guidelines in survivorship. We're hoping to get them to move these same guidelines into active treatment. I alluded to a paper that came out in March of this year that Karen Wonders and Katie Schmitz were two of the authors on. This was a cost savings analysis, prospective trial that I'll outline here in a second with early stage breast cancer survivors. We had 251 patients with early stage breast cancer, that's stages 1 and 2, who were randomized into 12 weeks of once weekly supervised exercise, and then given things that should be done at home versus usual care. What is usual care? Well, frankly, it's brochure therapy. It's telling people they ought to do it. And the study then followed up the patients on costs. And in green is the control group. These were two equally randomized group. And in the sort of yellow group are the exercise group. Overall fitness is up, muscle endurance, strength, flexibility, like we talked about in the data, overall data. But here's statistically significant impact of a decrease in total expenditures, inpatient time, outpatient clinic visits, office visits, and other impacts, particularly including ER and other impacts. So here, even from a prospective clinical trial, the numbers are quite real. These are all the groups that say we need to be doing it. As I said, we just need to see this implemented more and more. NCCN, for those of you who don't know it, NCCN is the National Comprehensive Cancer Network, which is a network of most of the comprehensive cancer centers in the United States. Their standards are sort of the overall gold standards for cancer care in all types of cancers. And they also produce standards for international settings as well. Also, the American Cancer Society is more and more involved in all of these other groups. I also alluded a minute ago to the NAPBC standards that are coming out. We're hoping that these remain in the final version, that we're crossing our fingers are going to come out later this month or next month, which basically say you need language at your center to document your policy for referring patients to exercise programming as a standard. And those 4 groups would be pre-surgical assessment, post-surgical referrals, referrals during chemotherapy and during survivorship. So again, more and more momentum moving in the right direction. Well, many of you are going to say, okay, Jay, those are great. All of this is great. How do you do it? Well, there's sort of fundamentally three different types of models. One is a group fitness model, and I'll discuss more about that in a minute. Another is a consultative model, and the other that I'm involved with at Mapletree is a one-on-one model. Live Strong, it would be a good example of a group fitness model at the YMCAs. Depending on what part of the country you're in, we have dragon boat groups. In other words, fit steps for life. There are all sorts of examples of group fitness models that are out there. We hope that the group fitness for cancer patients and survivor that they're offered by professionals who are specially trained in exercise oncology. The advantages are that you get involved with the group through their brochures or otherwise are physically actively involved. And however, they're completely offloaded from a clinic or a hospital. The disadvantage is that pure brochure therapy just doesn't work. If I take a brochure and hand it to a patient and say, you know what, you ought to really be exercising. What do you think the odds are that people are doing that regularly? And the answer is low. There are also some equity issues here. As well known as Live Strong is, it's only in the times it's been up and active at YMCA's, only about 6,800 survivors have actually been involved after nearly a decade. What's a consultative model? Well, this is where we've got basically somebody at a hospital setting where the assessment can be done by a professional. That's that assessment I was talking about. A prescription is done. If they need additional referrals, that can be decided upon. And the appropriate triage to physical therapy can be done. And the consultant, who is an exercise specialist trained, is embedded in the clinic setting. Its advantages are that it's personalized and personalized timing of when they're available. It addresses safety concerns. It's at the same location of where the cancer programs are going on, hopefully with no extra appointments, and it can be done with telemedicine. The disadvantages is that you need to have an exercise specialist on site, and more of these folks are available, and obviously a salary for that person. Then finally, the one-on-one model. Mapletree is an example of that. I mentioned last year we're in over 50 locations in the United States, 5 in Brazil, and a new location in New Zealand. And we're also reaching out internationally that I'll talk about in a minute. I've already gone through what these 4 stages are and phases are. It's a cancer rehab model. It's embedded within a cancer center or offered virtually as one-on-one. We can do it virtually very, very well. The model is the most personalized attention. It can serve as a triage tissue to physical therapists. The visual models work very, very well. We learned that during the pandemic. It's documented as the most effective, and most of the data from the clinical trials has really come from these one-on-one models. If there's any disadvantages is we would like to have space on site, don't always have to do that. It involves certified exercise oncology professionals. Let me outline who these are. They are typically bachelor level graduates, some master's level in kinesiology or exercise physiology, who we either put through or they can do it through the American College of Sports Medicine, a certification program for working with cancer patients. We'd like to have equipment on site, but even doing it virtually, it's amazing how much can be done at home. And there's usually a setup referral directly from clinicians. So as I've said, it really is effective. It improves the chemotherapy compliance rates. It's very, very cost effective when you look at it compared to all the other costs involved with overall cancer care. We feel more and more it's coming as the standard of care in the United States. The only question is which model would work best for our cancer program. We're working overseas internationally. What we're basically doing is exporting the materials developed at Mapletree, which includes video and manuals. We're already in mainland China and Hunan province, where our videos and manuals have been translated into Mandarin. We're just tiptoeing in and starting in Mexico, Italy, hopefully very soon in South Africa, almost ready to be into Sydney, Australia, and just starting up again with Serbia and Japan. Folks in these locations are helping us with translating the manuals and voiceover or words on the videos. For those of you that have a really major interest, Katie Schmitz, who I've talked about endlessly, who's one of the rural leaders in the United States and globally. Katie has got this book, Exercise Oncology, which I think will be the definitive textbook in academic and other centers, and then moving through cancer for lay people. That's basically it. I will stop my share. And Karen, I think hopefully you're still on. If you want to throw in any additional comments, Jay is going to be quiet, okay?
No, hey Jay. I think you did a great job. I think you did a great job summarizing not just our program, but a lot of the different programs that are available out there. Because as you said, we really believe that this should be standard of care, and we understand it's not a one size fits all approach. So well done.
Well, thank you very much. Karen Anderson, it looks like you're still on, and you all have been leaders down in Australia. If you're by your computer and want to join here, I haven't bored you to death with my talk.
No, it's wonderful, Jay. We can't thank you enough. This is awesome information.
Yeah, and one of the things, Peggy, with the advocacy groups that you're involved with, we would like to become involved with as many advocacy groups. I think the greater acceptance of this is going to come in two directions, basically, from the bottom up, mainly patients and advocates and advocacy groups like your own, and from the top down. We're working nationally trying to get reimbursement for exercise specialists. The American College of Sports Medicine is working very, very hard to try and make exercise specialists what are called QHPs, qualified health providers, so that reimbursement can be acceptable. So we're working vigorously on this. But the other big issue that we've got, and I mentioned it earlier, is an education issue. Namely, we want more patients to know not only the benefit of this, but frankly, we need more healthcare providers.
Yeah, to know it exists.
The majority of my colleagues in surgical oncology, radiation oncology, medical oncology, nurse clinicians, nurse navigators, and others, we all know that, quote, exercise is good. Very, very few people are aware of the kind of hard science that Karen Wonders and Katie Schmitz and all these clinical trials have really come up with. So the science is there. We just need more and more advocacy and more implementation of this in active cancer programs. But hey, guys, once again, thanks for having me back. I know we're small but mighty of those who are still left
Right.
on the line right now. Okay.
And do we have any questions for Dr. Harness here? Anybody? And if not, there we got Sherry Matthews, I think.
Hello, really great information. Of course, I'm loving every minute of this. My question to you, sir, is have you ever done any studies on intermittent fasting coupled with exercise while going through treatment?
Yeah, I'm not the right person to answer that. Karen, do you want to answer that? As I said, I'm the newbie. Karen's been at this a 11 years or more. Jay's just been at it 3 years, but I can comment that I know more and more medical oncologists are talking about that. Karen, do you want to comment about fasting?
Yes, I've actually thought about doing a study looking at that because I personally practice intermittent fasting and I have for the last 6 years. And I've seen limited studies in patients that have done intermittent fasting, but none that have coupled it with exercise. So I think that's a great research question to look into.
Okay, thank you. Dr. Oz actually did the announcement, not for cancer research, but for health and wellness. It'd be that after a fast from overnight and into the morning, late morning, your first exercise, let's say walking even, it was astounding how the impact on a cellular level to the body. But that might be a quick refer where to start, because he actually did the white pages on it. And so I was just asking that question because just through intermittent fastings, I've changed 100% of my blood panels for the better. I'm basically blood panel 30 years old now, just from intermittent fasting.
Sherry, I know you're one of the speakers coming up here. Tell us about yourself. Are you a survivor? And that's one of your interests in all this?
Yes, I am a survivor, actually in rehab. Just came out of surgery 2 days ago from a rebuild stuff. So I'm going to be practicing all the things that you are saying, as I did already, and also intermittent fasting. So that's what the question was led to that. Day after surgery, I went for a 1.8 mile slow controlled walk just to keep body going. It refreshed my mind. I felt stronger. And this isn't my first rodeo, so I know the difference. So
well,
yeah.
I know you're an upcoming speaker and you've got my email. Please email how to stay in touch with you. And Karen's got her hand up over there. So Karen,
Okay.
I see your hands up.
Oh no, that was me clapping.
Oh, that was you clapping. Oh, okay. Sorry. All
Yeah.
right. All right, Peggy. Hey, Peggy and Brett, thanks so very, very much.
Thank
I
you,
know we've got
Dr.
our next
Harness.
speaker coming. Thank you.
Definitely. And yeah, what you all are talking about, my youngest son, Bobby, preaches to us. Intermittent fasting, exercise, do it, mom and dad, you'll live longer. So we're working on it. So totally get it. Thank you so much.